Very good evening to all of you. At the outset, I would like to thank the organizers, Dr. Khalikur and Dr. Ruchi, for inviting me here and allowing me to be a part of Indo-US. So I'll be taking you through the journey of B chronic lymphoproliferative disorders, and I'll try to keep it as simple as possible. So what are B chronic lymphoproliferative disorders? These are tumors of the mature B cells. And these tumor cells tend to recapitulate the stages of normal B cell maturation. So if a tumor is arising from the germinal center, it will express the markers of germinal center. So all the tumors of germinal centers, like you enumerated in the last talk, diffuse B-cell lymphoma, Burkitt's lymphoma, follicular lymphoma, this will be CD10 positive. So any tumor, always try to recapitulate the site of origin. So when a patient comes to you, how do you start? You start with the clinical history. You check for the presentation of the patient, check for the organomegaly or lymphadenopathy. Go ahead with CBC, peripheral blood smear, bone marrow aspiration and treatment if required. And if the count is enough in the peripheral blood, you can go directly ahead with the immunophenotyping using flow cytometry. And for few cases, we need cytogenetic and molecular testing also. So this is the diagram from the WHO. And here you can see the various antigens that are being expressed with the various stages of B cell development. Yeah. So you can make out these are the immaturity markers like CD34, TDP, CD10, and LMO2. So they are being expressed at a very immature stages. So if these markers are positive, then you call it as immature tumor. And similarly, CD10 is being expressed by the germinal center cells. So any tumor expressing CD10, you think about the origin being from the germinal center. CD19 is a pan B cell marker and it is used, that's why it is used as a gating marker. Similarly, we have CD79A. CD20 is not expressed in the very early stages and it gets expressed in the mature stages. So this diagram shows the expression of various markers in the various stages of differentiation. All of us have read WHO classification of the B lymphoid neoplasm. Now, this is the article which came in 2022, the 5th edition of WHO classification of hematolymphoid tumor. In this, certain changes have been made in the previous classification and few new entities have been added and some of the older entities have been deleted. So just 2 minutes about this article. So initially in the 4th edition, we had a category of BPLL, that is B-cell prolymphocytic leukemia. This entity has been deleted now, and most of the cases that were in the BPLL category are now classified under mantle cell lymphoma or into the cases of CLL with prolymphocytic conversion. Similarly, there is a category of B-cell lymphoma unclassifiable with features between DLBL and classical Hodgkin's lymphoma. They have been reclassified into mediastinal Gray zone lymphoma. There is a new entity of reactive B-cell lymphoid proliferation that can mimic lymphoma. So this is a very important entity and all the monoclonal B-cell lymphocytosis cases fall over here. So although those cases have a clonal proliferation, but they are not neoplastic. Similarly, earlier we used to have a category of hairy cell leukemia variant. Now that hairy cell leukemia variant category has been subclassified into splenic B-cell lymphoma leukemia with prominent nucleoli, and it is no more a different entity. So what are the samples that can be used for the immunophenotyping? Anything which can be suspended into a fluid and can be made to run in a single file pattern can be used. So we can use a peripheral blood, we can use a bone marrow, we can use the FNA material from the lymph node or tissue mass, we can use the body cavity fluids like ascitic fluid, pleural fluid, or CSF, and even the biopsies from the lymph node and mass can be disintegrated into the smaller cells or the smaller tissue, how Dr. Hemant had described in his talk, and they can be used for the flow cytometry. So how does flow cytometry help us? It will help us to assign the lineage. We will know whether it is B lineage, T lineage, or myeloid lineage, whether mature or immature. We can assess the expression of the immaturity markers like CD34, TDP, CD99 to assess whether it is immature. We can check whether the cells are normal or abnormal because The abnormal cells will have a different immunophenotypic expression. Flow cytometry plots also tells us about the size of the cell because of the forward scatter and side scatter, and about the diagnostic and prognostic information. I am not going into details of all this because this has been covered by Dr. Khalipur already. So this is the 8-color panel which we are using at our center. So it is a very basic panel wherein we are using CD19 as a gating marker for most of the cases, and associated other markers are being used. And of course, you can increase your panel by adding any of these markers and upgrade the panel. So coming to the gating strategy for the B cell lymphomas, we use CD19 versus side scatter in most of the cases. You can go ahead with the CD45 versus side scatter also, but here the CD45 population will have T cells admixed with it. So in the subsequent gating, you have to use CD19 as well and further analyze those 19 positive cells. Why do we use 19 as a gating marker? Because 19 is consistently expressed throughout the maturation stages of the B cell. However, we have to be aware about certain conditions like anti-CD19 CAR T cell therapy and blinatumomab anti-CD19 therapy, where CD19 can be negative. What about CD20? Can it be used as a gating marker? It cannot, because CD20 is not expressed in the early stages of the B cell maturation. Early hematogones are CD20 negative. In certain B cell lymphomas like CLL and SLL, CD20 is downregulated, as well as CD20 is absent in the anti-CD20 therapy like rituximab. So we don't prefer to use CD20 as a gating marker. What about CD22 and CD79A? These are also the pan lineage marker, but CD22 is not very consistently expressed, and CD79A is an intracellular marker. So some of the labs will have a problem in assessing it. So considering all this, CD19 is a gating marker which is preferred. So how do we classify or how do we differentiate normal B cells from the abnormal B cells? For that, Dr. Jasmita has already explained in detail about the immunoglobulin light chain class restriction. So what is that? As Dr. Jasmita has explained, in the normal peripheral blood, we have the cells which will have, some of them will be kappa positive, some of them will be lambda positive. So this is called as polytypic or the reactive pattern. And the normal ratio is 1:2:1. So anything above 3 or less than 0.3 is considered to be abnormal. And here is a clonal population. So here you can make out most of the cells are kappa positive. So this is clear-cut a clonal or a neoplastic population. But again, here there are certain caveats which one must be aware, and Dr. Jasmita has already explained. Some B cells can be light chain dim or negative, like CLL or SLL. The B cells here will have dimmer or absent light chain expression. Certain reactive cells in the body fluid can have a dimmer expression of kappa and lambda. Germinal center B cells have dimmer expression of kappa and lambda, and blasts and hematogones are negative for kappa and lambda. Even in certain florid reactive hyperplasias of the lymph nodes seen in the HIV patients, in those cases, at times the cells will have either kappa expression or lambda expression, but they are not neoplastic. So assessing this clonality alone is not sufficient to call a cell as a neoplastic. We have to assess this along with the expression of the other markers in the neoplastic population. So we have to take the phenotyping in altogether, the expression of clonal marker as well as the expression of the other immunophenotypic marker. And not every monotypic population is lymphoma. As in case of monoclonal B cell lymphocytosis, these cases will be either kappa or lambda positive, but it's not lymphoma. In some cases of follicular neoplasia. Coming to the aberrant antigen expression. Any cell which is expressing the antigen which is not normally expressed by that cell is called as the aberrant antigen expression. And this is considered to be abnormal. Like expression of CD5 on B cells. Usually B cells don't express CD5. CD5 is a T cell marker. So if CD5 gets expressed by the B cell, then it's considered to be abnormal. Very few B cells like naive B cells might express CD5, but most of the B cells are 5 negative and 5 positive B cells are abnormal. Expression of BCL2 on CD10 positive cells is considered to be abnormal. CD10 is a germinal center marker and germinal centers are negative for BCL2. So if CD10 positive cell starts expressing BCL2, then it is abnormal. Expression of 13 or 33 by B lymphoid cells is abnormal. 13 and 33 are the myeloid markers and they should not be normally expressed by the B cell. So if B cells are expressing 13 or 33, it is considered to be abnormal. So size of the cell with the help of the flow cytometry, when you check the forward scatter versus side scatter, it will give you a clue about the size of the cell. Now looking at this peripheral smear, what can you make out? There is increase in the lymphocyte count, right? What is the size of the lymphocytes? The size of the lymphocytes? Small size when you compare with the RBCs, and background is showing lot of smudge cells. So what is your morphological diagnosis? CLL. Now this is the plot SSC versus FSC. So small size cells will usually come and lie here. They are lower on the side scatter and they will be occupying the region occupied by the lymphocytes. So looking at the FSC versus SSC, you can have an idea about the size of the cell. So most of the CLL, SLL, follicular lymphoma, marginal zone lymphoma, and some cases of LPL may fall into this category. Okay, what you can make out about the size? What is the size of the cell? Medium, approximately medium sized cell. How is the cytoplasm? It is irregular with some hairy projections. And look at this plot. The cells are coming slightly higher up on the side scatter. So this forward scatter versus side scatter gives you a very good clue. So cases of hairy cell leukemia, follicular lymphoma, and the Burkitt's lymphoma, where you have medium size, small to medium size or medium size cells, will have this kind of scatter plot. And look at this. You have cells which are larger in size. And look at this plot, FSC versus SSC. Cells are slightly higher up on the, they are much higher up on the side scatter when compared to this and this. And 45 versus side scatter, they are almost coming and lying in the monocytic region, right? Usually this area on the 45 versus side scatter is occupied by the monocytes. This P2 is your mature lymphocytes. So here the cells are almost coming and lying in the monocytic region. So this kind of scenario is seen in large B cell lymphomas like DLBCL or THR-BCL. So this is a very good article by Craig and Cohn on the flow cytometric immunophenotyping of the hematological neoplasm, where they have classified the mature B cell neoplasms into CD5 and with the help of CD5 and CD10. So in the subsequent 3 to 4 cases, I will tell you how to use this classification. Like CD5 positive and 10 negative lymphomas are usually CLL, SLL, mantle cell lymphoma, PLL, marginal zone. 5 negative and 10 positive are all those lymphomas which are arising from the germinal center, like follicular, DLBL, Burkitt, and very, very few cases of hairy cell. 5 negative, 10 negative is usually hairy cell, marginal, some cases of DLBL, some cases of follicular, and 5 positive, 10 positive is a very rare entity. Or you can use this algorithm also, wherein we take the CD5 positive cells. If the 5 is positive, check for the expression of CD23 and FMC7. If CD23 is positive, FMC7 is negative, it is CLL. If 23 is positive, FMC7 is also positive, it is PLL. If both are, if CD23 is negative with FMC7 positive, it is mantle cell lymphoma. And of course, further you have to do the cyclin D1 or translocation studies. If 5 is negative, check for the presence of CD10. If CD10 is positive, check for all the germinal center tumors. If the CD10 is negative, we think about the tumors which can have the hairy projections like hairy cell leukemia variant, or certain marginal zone lymphomas. So we check for the other markers. So this is another approach. So with this, I come to the first case. 60-year male with leukocytosis and lymphadenopathy. TLC is very high, around 60,000 and 80% lymphocytes. This is the characteristic peripheral smear. So what it is from the peripheral smear? It is a small cell lymphoma, most probably CLL. Okay. Now you have gated the singlets On the SSC versus FSC, most of the cells are lying in the lymphocytic region. We have gated the 19 positive cells here, and this is the kappa and lambda tube. So you can make out we are getting a very dim expression of kappa here. Bright expression you would have got somewhere here. So this population is coming here, some cells are negative, some are dim positive for kappa. Let's see the other markers. What about CD23? Positive or negative? It is heterogeneous in expression. Why heterogeneous? Some cells are negative, some are intermediate, some are positive, right? What about CD38? CD38 is negative. So what about CD5 and what about CD5? Bright positive. 45 is positive. What about CD20? It is heterogeneous in expression. FMC7 is negative. Okay. What about CD200 and CD20? 200 is bright and 20 was heterogeneous. 48 is negative and 73 is also negative. So we have a 5 positive, 10 negative lymphoma which has heterogeneous expression of CD20, dimmer expression of kappa, and this is a characteristic phenotype of the chronic lymphocytic leukemia. So you have 5 positive, 223 very bright, 20 heterogeneous, dim kappa, FMC7 negative, 38 may or may not be present. So how do you differentiate CLL from PLL? CLL cases have 20 dim, surface immunoglobulin dim, and even 79 dim, whereas PLL has brighter expression of these markers. CLL is 23 positive and PLL is 23 negative, 5 can be present or absent. And 200 is characteristically positive in CLL, where it is absent in the PLL. 200 expression is most of the times seen in CLL and hairy cell leukemia. It is very bright in these two conditions. I haven't come across other lymphomas which express CD200. In some cases of mantle cell lymphoma, there can be dimmer expression of CD200. So this is a very helpful marker, CD200. And what about mantle cell lymphoma? These lymphomas are 5 positive, 19 positive, 20 bright positive, 79 B bright positive, whereas they are negative for 223. And further, we have to take the help of expression of cyclin D1 or translocation 1114. Okay. So CLL has a dimmer expression of surface immunoglobulin. It will have a dim or a heterogeneous expression of CD20, and it will be bright 200 positive, 5 positive and 23 positive. So this is a classical immunophenotype of CLL. This BPLL category has been removed from the 5th edition of the WHO, and most of these cases are classified either into the mantle cell lymphoma or into the CLL, which has undergone conversion to the, which has more than 15% pro-lymphocytic cells. This is case 2, 53-year male with weakness and splenomegaly under evaluation. TLC of around 1 lakh with 44% lymphocyte. So what you can make out from this smear? There is increase in the lymphoid cells. What is the size of these cells? Around medium size, right? Okay, another smear. This is the singlet, and you can see the 19 positive population here. So is it clonal or not clonal? Clonal, showing kappa expression, right? Okay, what about this? CD5 is heterogeneous positive, I can say. These are the, what are these blue cells? Yeah, these are T lymphocytes, okay? So when you, in flow plots, always you can take the help of the internal controls. Like for the T markers, your few T lymphocytes that are present, that will be internal control. For B markers, the normal few B lymphocytes will be present, that will act as the internal control. For CD10, your granulocytes can act as the internal control. So 5 is heterogeneous here, 23 is negative. What about 200? You can say dim and heterogeneous. 45 is bright. CD20 is, this is CD20, okay, so it is bright, and CD38 is heterogeneous. What about this plot? Okay, CD10 is negative. FMC7 is heterogeneous and positive, and T cell markers are absent. Okay, so again, this is a 5 positive, 10 negative lymphoma. So because 20 was bright here, okay, and 200 was not being expressed. So we thought in terms of marginal zone lymphoma or mantle cell lymphoma, but here again you have to do confirmation with the help of cycling D1 or translocation studies. Cycling D1 can be done with the help of flow cytometry, but at our center we are not using on flow. We are doing cycling D1 on the histopathological sections. So this is a case number 3, 52-year female with dry cough and chest pain, follow through case of pancreatitis. Now she has a 8 centimeter palpable spleen. TLC is 3500. So TLC is reduced here. It's not increased. She has, but 65% cells are the lymphoid cells and associated with thrombocytopenia and anemia. Okay, now with the help of side scatter and forward scatter, can you comment on the size of the cell here? Medium size, okay. Medium, probably, or medium to large, probably medium. Okay. You have gated the 19 positive cell. Clonal or not clonal? Clonal, some kappa clonality it is showing. What about 23? Bright 10, negative. 220, positive. 5 is, 38 is, okay. What about 123? Most of the subset is positive. FMC 7, negative. 11C, heterogeneous. And 25 and 103, positive. So this is a case of hairy cell leukemia, and these are the pictures. Like you can make out, these are almost medium to slightly large size cells with irregular cytoplasmic projections or the hairy projections. Okay, so how to differentiate hairy cell leukemia from the hairy cell leukemia variant and other lymphomas which can have the villus projections on the cells like small marginal zone lymphoma. Although this category of hairy cell leukemia variant has been deleted from the 5th edition, and most of the cases of this are classified into splenic lymphomas with prominent nuclei. So usually hairy cell leukemia presents with low WBC count, as in this case, whereas the variant will have an increased WBC count. Most of the cases of hairy cell leukemia are 103 and 25 positive, whereas these are 103 positive but 25 negative. 123 is bright here, whereas here it is dim. Now, splenic marginal zone lymphoma can also have the villus lymphocytes. These are also 11C positive, but 200 is negative here, and 305 is also negative, whereas 200 was very brightly expressed in the cases of hairy cell leukemia. This is a case for 33-year male with recurrent vomiting and weight loss associated with pain abdomen. CT abdomen showed eccentric heterogeneous lesion in third part of duodenum up to the duodenojejunal junction. Mesenteric and retroperitoneal lymphadenopathy was present, and patient also had ascites. So this is a bone marrow smear. So what you can make out from here? Is it a lymphoma or not? Looks like, because there is increased number of lymphoid cells which are large in size, right? Some of them are showing prominent nucleoli. They have irregular nuclear margins. Okay, so you can make out the morphology here, the prominent nucleoli. Now, FSC versus SSC, the cells are coming slightly higher up on the side scatter. So the size and slightly forward on the forward scatter. So these cells are slightly larger. And when we see the 45 plot, these cells are almost coming up to the monocytic region. I think one thing I have mistaken, probably this side scatter is for the nuclear complexity and granularity, and the forward scatter is for the size. So if the cell is bigger, it will come slightly forward on the forward scatter. Okay. So in the previous plot, I think I told it opposite. Okay. So we have gated the 19 positive cells here from the 19 versus 45. So what you can make out, the cells are 10 positive. Okay. They show brighter expression of 28 and 38. And 5 and 2, the T cell markers are negative. What about CD200? It is negative. FMC7 is heterogeneous. And what about the lambda? The clonality, these population are clonal. The T cell markers were negative. So this is a 10 positive lymphoma arising from the germinal centers. So all the in differential, we have follicular lymphoma, DLBL, and Burkitt's. So this case was that of a diffuse large B-cell lymphoma because the cells were very large in size. In follicular lymphoma, you will see the cells which have a small size cells, almost small to medium size with the cleaved nuclei. These were the tissue biopsies that we received, the intestinal, showing the intestinal mucosa, showing the diffuse infiltration by these lymphoid cells. And on the biopsy also, we had put up the markers which are 20, 10, BCL6 positive, Ki67 index very high, MUM1 and BCL2. So this was the case of diffuse large B-cell lymphoma. These are the defined sections showing the infiltration by the abnormal lymphoid cells. This is another case, 47-year male with history of weakness, joint pain, abdominal discomfort, palpable spleen and liver, and cervical and axillary lymphadenopathy. You are seeing almost the medium-sized cells with a nice nuclear cleaving. So morphologically, what it is? This is morphologically small cell lymphoma, probably small to medium-sized cells, probably follicular, probably yes. But here on the 45 versus side scatter, we got two population of cell. One is bright 45, one is almost approaching this area, probably slightly moderate to dimmer. And we have gated both the populations separately. So CD10 is bright, 19 is bright. So these are the granulocytes which act as the internal control for CD10. 38 and 25 are negative, 20 and 10 are, 20 is very bright here. So we know we are dealing with a mature B-cell neoplasm. Okay, and T cell markers are absent. What about kappa and lambda? Sorry, this is 34 and 38 is negative. Okay. Now, we had put the myeloid tube also in this. So myeloid markers are negative. HLA-DR is bright positive. What about kappa and lambda? Will you call it negative or will you do something else now? इस केस में हमने immaturity markers भी लगाए थे 34, TDT 19, but they all came to be negative and CD20 is bright here. So what will you do now? You will repeat the clonality tube after washing the specimen 2 to 3 times. Pardon me, something. Okay. So in such cases, you have to repeat the clonality tube. You have to repeat this experiment. And finally, we got kappa restricted population in this case. So this was a case of hairy cell leukemia. We had put up cytoplasmic 22, which also came to be positive. MPO was negative and cytoplasmic CD3 was also negative. So this was a case of follicular lymphoma. So in brief, this is a tabular chart showing all the BCLPDs and the expression of various markers, which I have just explained. And take-home message, diagnosis of BNHL is a combination of morphology, immunophenotype, and in some cases, we require cytogenetic and molecular studies also. Size of the cells gives a clue more often. 19 versus side scatter is the most reliable gating method for BCLPD. And we have to check for the expression of the kappa or lambda restricted population or the clonal population. But we have to be aware about certain caveats, how Dr. Jasmita has discussed. If you're getting kappa and if you're not getting kappa and lambda properly, repeat the experiment by giving it 2 to 3 washes. And sequential algorithmic evaluation will help reach the diagnosis. Check for the presence of aberrant markers or altered intensity of markers, which will give you a clue whether those cells are normal or abnormal. So thank you for your patience listening. This is the faculty from the Department of Pathology. And among them, we have Dr. Geeta and Dr. Millie and Dr. Sanjay, who are in lymphoma, leukemia, and hematology lab in TGMU. Thank you so much.